Our next speaker is Professor Wilfred Peh from Singapore. Wilfred's from almost retiring musculoskeletal radiologist at KHOA Hospital. I consider him my mentor in musculoskeletal radiology. He was the person that sort of pulled me into the Asian Musculoskeletal Society and forced me to do work after he decided to have a break from leadership. Wilfred is a superstar in musculoskeletal radiology, and anywhere you go in the world, people, if you say you're from Singapore, the first question they'll ask is, oh, how's Wilfred? Okay,
thank you.
Take it away.
Yeah, thank you very much, Stephen. Very kind of you for the nice introduction. So my topic today will be on imaging of necrotizing fasciitis. All my figures are from these publications, published over the last few years. And the last publication will be a book that will be published by Springer later this year. So the outline of my talk will be the introduction. I'll talk about anatomy of the fascia in the limbs, MR features of necrotizing fasciitis, and some pitfalls and limitations of which can mimic necrotizing fasciitis, ending with a summary. So necrotizing fasciitis is a life-threatening soft tissue infection, usually of bacterial origin. It involves mainly the deep fascia of the limbs. It is a rapidly progressive necrosis and is regarded as a surgical emergency. So diagnosis is really important. It can result in complications of organ failure, sepsis, and shock with a high mortality rate. So the diagnosis is important. A quick diagnosis is important. Patient usually needs immediate hospital care, antibiotics, and often surgery. The early symptoms are fever and severe pain. Patient usually has swollen limbs. The infection usually spreads quickly, and the later complications are listed here: skin color changes, diarrhea, nausea, fatigue, black spots on the skin, blisters, ulcers, and oozing pus, and these are usually very bad symptoms by the time the patients get them. There are several groups of causative organisms divided into 4 types. The most common type is multiple organisms, usually a mixture of anaerobic and aerobic bacteria. Less common are only one type of bacteria, usually Streptococcus. The gas-forming bacteria, like Clostridium, is less common, but you often see radiographs of this showing gas because it looks nice on radiographs. And fungal infections are really rare. Personally, I don't think I've come across a single case of fungal infection causing necrotizing fasciitis. So in summary, the commonest one would be a mixture of anaerobic and aerobic organisms. There are some risk factors and associations as listed: intravenous drug use, diabetes, immunosuppression, obesity, peripheral vascular disease, and recent surgery. So clinically, early recognition is usually a problem because it's not a very common disease. The initial clinical signs are usually quite non-specific. Patient comes in with painful swelling of the limbs, and MRI is the most useful imaging method for diagnosis. So most of my talk will focus on MRI features of necrotizing fasciitis. So in my next few talks, I will talk about anatomy of the fascia. The fascia anatomy can be divided into superficial and deep fascia. So this is a diagram from one of our publications showing a cross-sectional image of the fascia from skin to bone. So starting with superficial fascia, this refers to the layer of adipose tissue which connects the skin to the deep fascia. In between the superficial adipose tissue and deep adipose tissue, there's a membranous layer or superficial fascia. So as shown in this diagram, we have the red box indicates the superficial fascia. So this is superficial adipose tissue, the deep adipose tissue, and this is the membranous layer, which you can sometimes see labeled as B. The deep fascia are dense connective tissue which surrounds the muscle and other deep structures. So there are two layers, a peripheral layer and an intermuscular layer. And this is better appreciated in the diagram. So it's in the red box. So we have the muscle here. This is the peripheral layer. And this is the intermuscular layer. So these are the important layers because we look for fluid on MRI affecting these two layers. So this MRI image showing the layers. So the important ones are in red. This is the peripheral layer of the deep fascia. In the green line shows the intermuscular layer of the deep fascia. And the yellow line is just the membranous layer, which is in the superficial fascia. So that is less important. Okay, so MRI is the preferred image modality because it shows the soft tissue the best and is the choice of modality of choice for necrotizing fasciitis. The roles of the other modalities are generally limited. So on radiographs, we look for soft tissue gas, especially if there's a necrotizing fasciitis is due to a gas-forming organism. And the other sign is less specific, soft tissue swelling and edema, which you can get in a variety of other conditions. So here's a nice example of a very classical necrotizing fasciitis seen on radiographs. The yellow arrow points to obvious gas within the soft tissue. And you can also see that there's a lot of soft tissue swelling. So a nice example of necrotizing fasciitis due to a gas-forming organism. CT can show intermuscular fluid collections and fascial thickening, but not as well as MRI. And ultrasound also shows fluid collections in the deep fascia. Ultrasound is also useful for guiding fluid aspiration. Here's an example of a 74-year-old female who presented with pain and swelling of the right thigh. And the upper image shows an ultrasound, longitudinal ultrasound. The arrows point to hypoechoic areas of fluid in between the muscles. So this is within the intermuscular fascia. And the series of axial images at the bottom, these are MR images, T1, T2 with fat set in the middle, and on the right, post-contrast with fat set, T1 image with fat set. And the open arrows point to fluid in the intermuscular fascia, so you can see it's between the muscle groups. And there is some enhancement on the right image, which is the post-contrast image. This is another patient, a 33-year-old female who presented with typically pain, swelling, and this time crepitus of the right thigh. And the radiograph on the left shows a lot of gas in the soft tissues. And on MRI, you can see there are black areas of signal void as indicated by the arrows. These represent gas, and this is better seen on the T2 weighted images. So the standard MR sequences would be typical for musculoskeletal radiology, T1, fat saturated T2 or stir, and the post-contrast T1 with fat set. And if gas is suspected, it's useful to add a gradient echo sequence where the gas will bloom. Axial image is probably the most useful one with one orthogonal plane. So this with the minimal images and sequences for MR imaging for necrotizing fasciitis. So this is another patient, a 71-year-old man. The radiograph of the forearms show a few streaky areas indicated by yellow arrows. You can see streaky areas of gas within the soft tissue. And on the MRI, the yellow arrow points to hypoechoic areas. On the left, a T2 weighted fat saturated image. And on the right, a gradient echo sequence which show blooming of the gas. And the T2 weighted image shows fluid in the intermuscular fascia as indicated by the red arrows. And this patient underwent urgent surgery to relieve his necrotizing fasciitis. So this is probably the most important slide showing the MR features. You look for T2 hyperintense signal or fluid signal in the deep fascia, especially the intermuscular fascia. You look for deep fascial thickening of 3 millimeters or more, so that should be thick fluid collection instead of just streaks of fluid. And often there is extensive multi-compartment fascial involvement. That means interfascial fluid that involves more than one muscle group. So these are very strong. If you have all these 3 features, these are all strong features of necrotizing fasciitis. Contrast enhancement is variable. So you can get no contrast enhancement, very slight contrast enhancement, or contrast enhancement that corresponds to the area of fluid on the T2 weighted sequences. And quite often you also get some reactive muscle edema. So there's increased fluid, increased signal in the muscles adjacent to the areas of fluid collection, deep fluid collection. So here's an example, 50-year-old patient with surgically proven necrotizing fasciitis. T2 weighted image on the left shows intermuscular fascial fluid between 2 groups of muscle indicated by the yellow arrows. The red asterisk indicates some muscle edema. And on the right is a contrast enhanced image which shows very little contrast enhancement. So this is an example where there's almost no contrast enhancement in the patient with necrotizing fasciitis. So here's another patient, a young patient, 19-year-old female. This was subsequently operated on. T1 on the left, T2 on the right, and post-contrast, bottom left corner. And there's hardly anything to see on the post-contrast or the T1 weighted image, but the T2 weighted image shows a lot of fluid in the intermuscular fascia as well as the peripheral fascia of the peripheral deep fascia. So this, the diagnosis of necrotizing fasciitis can be made quite easily. Okay, here's another patient, a 21-year-old male with swelling of the calf. T2 weighted image on the left, T1 with post-contrast fat saturated image on the right. And again, you can see a collection of thickened collection of fluid in the intermuscular fascia indicated by the yellow arrows. And the red arrows on the right shows there is moderate contrast enhancement, which corresponds to the areas of T2 hyperintensity. 37-year-old man who had previous surgery for necrotizing fasciitis. And this is a series of follow-up MRIs. So the limb on the this side, the left-hand side is normal. On the right-hand side, you can see that there is fluid in the thickened intermuscular fascia with some enhancement, partial enhancement. So this necrotizing fasciitis, again, occurring in the previously operated patient with typical T2 signal, thickened T2 signal, and some enhancement. So what are the mimics of necrotizing fasciitis? So you can get cellulitis. So MR is useful because often the patient comes in with swelling and pain in the limbs, and you can't really tell cellulitis from necrotizing fasciitis, although necrotizing fasciitis tends to have disproportionate amount of pain. But the MR will sort this out quite easily. There's infection of the muscles. And then it can be due to trauma and inflammatory conditions. So I'll show you some examples. So cellulitis is essentially superficial infection of the skin and superficial fascia. You can get deep cellulitis. It doesn't really affect the intermuscular fascia, but often affects the deeper part or the peripheral part of the, near the peripheral part of the deep fascia. So here's an example. You can see the muscles are quite normal. There is no fluid in the intermuscular fascia or close to the deep muscles, but there is a lot of fluid in the superficial fascia, including the membranous fascia. So here's another example, a different patient with deep cellulitis of the thigh. The yellow arrow points to a fluid within the membranous fascia, and the red arrow points to fluid just outside the peripheral layer of the deep fascia. But if you look at the muscles, they're all normal, and the intermuscular fascia and the peripheral layer itself are normal. So this is just a deep cellulitis. Here's another example of cellulitis. So there is a little bit of fluid indicated by the red arrows in the intermuscular fascia, but this is just a small area, and most of the fluid is in the superficial fascia. So this is cellulitis of the calf with just a small area of intermuscular deep fascial extension. And this patient responded well to antibiotics. The patient didn't need surgery at all. Here's an example of infective myositis. So T2 X-ray image on the left, post-contrast image on the right. It shows no fascial fluid, but there is increased T2 signal affecting several muscles, which enhances on the T2 weighted sequence. So this is myositis and not necrotizing fasciitis. Okay, this is a patient who, if you look at the right image, the T2 weighted image, it looks like there's a collection of fluid, a linear, curvilinear collection of fluid. So this looks like necrotizing fasciitis, but this is a patient with injury, and the yellow arrow points to a tear in the gastrocnemius muscle, and that's just fluid tracking along the peripheral layer of the deep fascia from the area of tear. So this is it's just a muscle injury with fluid collection rather than necrotizing fasciitis. And this is another example, a patient who had painful calf swelling for 1 month, no history of trauma. And this is a nice example of a ruptured Baker cyst. So clinically, it mimics necrotizing fasciitis because it's painful swelling of the calf. But you can see that the fluid extends from the knee joint, and it just tracks into the gastrocnemius muscles, gastrocnemius and soleus muscles. So this mimics necrotizing fasciitis, but it's just a ruptured Baker cyst. Okay, last example, they can all coexist. So this is a 44-year-old male patient with renal impairment. And from the 2 T2 weighted image taken at the upper calf and mid calf, you can see that he has extensive fluid collections in the superficial fascia, in the deep fascia, and there is a lot of fluid, a lot of signal change, increased hyperintense signal in the muscle. So this patient has got cellulitis, infective myositis, as well as necrotizing fasciitis, all in one patient. So in summary, MR is the most useful modality for diagnosis of necrotizing fasciitis. The important signs are fluid signal in the thickened intermuscular fascia, layer of the deep fascia. It got to be thickened, and ideally it should involve more than one muscle group. early diagnosis will enable timely and appropriate management of these patients. Yeah, thank you very much for your attention.
Stay where you are.